Welcome to Specialist Unplugged podcast, brought to you by the Southwestern Sydney Primary Health Network in collaboration with Highlands Specialist Hub, where we bring expert insights to support healthcare professionals. Today's episode focuses on chronic kidney disease, its diagnosis, management, and long-term monitoring, and we are joined by two esteemed doctors to explore this important issue. Hosting our discussion is Dr. David Grice, and our guest speaker for today is Dr. Paul Nguyen. I'll now hand it over to both of you to introduce yourselves and get us started on today's conversation.
Thank you. Well, hello everyone. You're joining David Grice, Barrel GP, and we welcome you to this webcast, brainchild of Naomi from the Highlands Specialist Hub and Alison from the Southwest Sydney PHN. We're delighted to welcome Dr. Paul Nguyen, a nephrologist who's recently started consulting in Barrel at the Highlands Specialist Hub. So welcome, Paul.
Thank you very much, David, for the kind introduction and for the invitation today to discuss what I think is a very important topic, that is chronic kidney disease. So a little bit about myself. I am a nephrologist with a special interest in all areas of nephrology. I finished my training in 2023, and following that, I did go on to do a year of general medicine before deciding to practice in Barrel. So for today's talk, I thought I'd give a quick overview of the diagnosis and management of chronic kidney disease, commonly abbreviated as CKD. In Australia, as you know, CKD is a growing health concern, and it's estimated to affect over 10% of adults, with 3 out of 4 over the age of 18 at an increased risk of developing CKD. As you know, it is associated with a significantly elevated risk of cardiovascular disease. And furthermore, many patients may generally be asymptomatic until their kidney function declines to very low levels. And this, I think, highlights the importance of early detection and intervention, particularly in those at increased risk of chronic kidney disease.
Yeah, certainly in general practice, we see a lot of it, and often I see people who might, from dehydration or another illness, get a slight rise in creatinine, and you tell them to drink more, and they seem to recover a little bit, and then next episode, and it's just over the years it can creep up on you. So I'd be keen to know at what stage you feel we should intervene as general practitioners and what tests we should do. We often will do lipids and kidney function and liver function, thyroid, prostate for men, etc. And I'm just wondering whether as GPs we should add in a spot microalbumin to that yearly blood test.
Yeah, certainly. I mean, as part of patients undergoing what we call a kidney health check, checking the albumin creatinine ratio along with their blood pressure and their GFR would be part of that kidney health check. And I would certainly recommend you checking in a urine albumin in patients who are particularly high risk for chronic kidney disease, such as those with diabetes, hypertension, established cardiovascular disease, along with those over the age of 60 and Indigenous Australians over the age of 18 who we know are significantly elevated risk of CKD.
Yeah, and do you feel like a yearly spot microalbumin in those people is adequate, or would you do it more often than that, or does it depend on previous results?
Yeah, so in those patients, it's generally recommended they have albuminuria checked an annual to 2 yearly basis. And that would be certainly reasonable. If you can see that things are progressing or evolving quite rapidly, then it would be useful to check it more frequently than that.
Okay, and at what stage would you recommend, obviously it depends on the patient, their age and other medical problems, and at what stage would you recommend referral to a physician such as yourself?
Yeah, so there are instances where a nephrology evaluation would be warranted. So in circumstances where patient's eGFR is declining quite rapidly, where patients may have signs of acute nephritis, for instance, so that would include oliguria, hypertension, along with peripheral edema, or when there is a sustained decrease in eGFR of 25% or more within 12 months, or a sustained decrease in eGFR of about 15 mils per year, along with evidence of persistent macroalbuminuria and difficult to control hypertension, where a patient is, say, on 3 or more medications. So those would be instances where I certainly recommend referring patients for a specialist opinion.
Okay, and in those patients, is there anything that we can do as GPs to help you or help the patient in the interim? I have no doubt that you would see people urgently if required, but often there will be some weeks or months waiting to see you. Is there anything that you would like us to do? Is it worth doing a 24-hour or an ultrasound? Or I guess it depends on the patient as well.
Yeah, like as you said, it depends on the patient, but at the very least, I think patients should have their blood test results, any results of their blood pressure and previous blood pressure results, along with their urine albumin creatinine ratio and renal imaging, such as a renal ultrasound or a CT. So these would be the minimum number of tests which would help us reach a diagnosis and manage these patients.
Yeah, I guess also you'd look at their medications and see if there are any nephrotoxic drugs that they're on. A lot of people are on ACE inhibitors, and I know that can put creatinine up. Do you have a level that you're kind of comfortable with, or that you feel we should stop ACE inhibitors?
Yeah, so we do know that after patients commence an ACE inhibitor, there may be a slight decline in their renal function related to the hemodynamic effect of these medications. But an acceptable rise will be anywhere up to a 30% decrease in eGFR. But in the scenario where you do have a patient that has had a greater than 30% decrease in eGFR, it would be, first of all, important to evaluate the patient as you would for any other patient with an AKI and determine whether it is related to a pre-renal or post-renal cause. And then following that, assess their medications for any other potential contributors to eGFR decline, such as diuretic and NSAIDs, before considering the possibility of renal artery stenosis. So in that instance, you may want to consider reducing the dose of the ACE inhibitor or stopping the ACE inhibitor altogether if there is a significant decline in eGFR while you're working up the patient and trying to figure out what's the cause of their eGFR decline.
Right. And in terms of non-steroidal anti-inflammatories, a lot of people use PRN. Is there, and again, I'm sure it depends on the individual, but is there kind of a safe level if they do get significant benefit with a short course? Or I guess it depends on what it is doing to their eGFR, and just test regularly. Is that a reasonable approach?
So, yeah, as you know, NSAIDs can have a deleterious effect on kidney function. So we do recommend that NSAIDs be avoided in patients with chronic kidney disease, especially when you're reaching very advanced stages, so those with eGFR less than 30. However, in some instances, there may be a role for, say, a short course of a short-acting NSAID, but generally, I would recommend that the NSAIDs be avoided.
Good. And recently, the SGLT2 inhibitors have been indicated for kidney disease. Could you comment on that and whether it's appropriate for GPs to initiate those?
Yes, first of all, the treatment paradigm for the management of CKD has really changed over the last 10 years to not only include SGLT2 inhibitors, but now you also have non-steroidal mineralocorticoid receptor antagonists along with GLP-1 receptor agonists as well, alongside traditional RAS blockade. And these medications have been shown to have a renoprotective effect with the benefit of slowing kidney disease progression. With SGLT2 inhibitors in particular, they have been shown to slow progression of CKD, regardless of diabetes status, along with also having a positive effect on cardiovascular risk and cardiovascular death. So I certainly think GPs, if capable, it would be appropriate for GPs to prescribe these medications if they are indicated. Furthermore, when you have a CKD patient who may not necessarily fulfill the criteria for an SGLT2, but they do meet its indication for other diseases such as the presence of heart failure and diabetes, then the use of SGLT2 inhibitors would also be recommended in those circumstances.
Yeah, it's certainly made it a lot easier for us to prescribe, and the indications that seems to be bordering on miraculous. So just someone whose creatinine is gradually creeping up over the years and they're well otherwise, is there a creatinine at which point you would say they definitely should see a nephrologist?
Yeah, so I would be looking more at their eGFR, whether they would warrant a nephrology review. So, as you know, kidney function does decline with age, and it's generally accepted that from the age of about 40 onwards, patients may have a decline in eGFR of 1 ml per minute. So, it is safe for patients with CKD to be managed in the primary care setting until they reach threshold of say 30 mils per minute where they would benefit from a nephrology review. But as I've said, if there's any other indication apart from that, such as a rapidly declining EGFR, or there's features of glomerulonephritis, or there's any other concern, then they should be referred for a specialist opinion.
Good. I think they were the main questions that I had from a general practice point of view. I guess we know or discuss what people can do for their liver health, and most people, I think, in terms of their renal health, or general advice in terms of drinking plenty of fluids, if it's safe from a heart point of view, and minimising nephrotoxic drugs. Anything else in terms of advice with regard to fluid intake or electrolytes or supplements or anything else that we can help our patients to help protect their kidneys?
Yeah, so I always like to advise my patients of just simple lifestyle modifications, like adhering to a healthy diet. It's now recommended that patients consume a predominantly plant-based diet with avoidance of ultra-processed foods, whilst also avoiding excessive salt and sugar intake, which may certainly have a negative impact on their blood pressure and glycemic control. It's also recommended that patients aim for at least 2.5 hours of moderate exercise across the week, along with maintenance of a healthy weight, according to BMI and waist circumference. We also know that smoking and vaping can result in accelerated CKD progression. So advising patients to stop smoking and vaping would also be part of that lifestyle modification strategy.
It sounds like what's good for the kidneys, good for the liver, the brain, and the heart, and the rest of you as well.
Yes, that's right. Yeah.
I don't have any further questions. Maybe a little bit about yourself in terms of how often you're down consulting in Bowral, and maybe a little bit about hobbies, interests, that side of things.
Yeah, so at the moment, I'm down in Barrow perhaps about once every couple of months. Apart from enjoying spending time with my family, I'm also a fitness fanatic, so I enjoy going to the gym and weight training 3 to 4 times a week. But I'm also a soccer tragic as well, so you can, if I'm not consulting and seeing patients, you will probably find me looking up the latest soccer score on Google. So
Which team do you follow?
So I've been a lifelong Arsenal supporter since I was a kid. So Arsenal have been my soccer team for a very long time. But if we were to talk about the A-League, then it would be Western Sydney Wanderers.
Very good. I'll still talk to you despite all that.
Yes.
Well, thank you so much for your time today. Unless there's anything else that you particularly want to share with us, we really appreciate your practical and interesting comments, and we look forward to meeting you in person. And thank you for looking after our renal patients. I'd like to thank Naomi and Alison and Kashish for their help in organising this. And unless you've got any other parting comments, I'll wish everyone a great day.
Thank you, David.
Pleasure. Thanks.